From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to our listeners from around the world. We're so pleased you've joined us for this JAMA author interview. I'm Dr. Tracy Lieu, Deputy Editor at JAMA and a pediatrician and researcher with Kaiser Permanente. Today, I'm very pleased to welcome Dr. Brett Manley, author of an exciting new study in JAMA titled Intratracheal Budesonide mixed with Surfactant for extremely preterm infants. Dr. Manley is a neonatologist at the Royal Women's Hospital in Melbourne and professor at the University of Melbourne. Is it okay if we proceed on a first-name basis?
Absolutely, Tracy. Thanks for having me.
Brett, your trial was a major effort among 21 neonatal intensive care units in 4 countries. For our listeners, could you give us the context of why intratracheal corticosteroids were the intervention you chose to evaluate?
Thanks, Tracy. The first thing to say is that as neonatologists and as a community, we're striving to improve the outcomes for our smallest and sickest babies, those born extremely preterm before 28 weeks of gestation. And what we're seeing is an increasing survival in our smallest babies. And now we have babies around the world, including in North America and Australia, that are surviving at 22 and 23 weeks more consistently. And what we're seeing is, in fact, a higher rate of the major respiratory complication of extreme preterm birth called bronchopulmonary dysplasia, or sometimes called the chronic lung disease of prematurity. This really is the bane of our clinical existence. It seems that because of the multifaceted pathophysiology of BPD and the fact that these tiny babies are exposed to so much inflammation in the intensive care unit and even before they're born, it's something that we've just not been able to reduce significantly. Corticosteroids, which are anti-inflammatories used, of course, for a multitude of reasons, are very effective against BPD when given systemically, such as into the bloodstream or into the stomach. However, they're associated with brain side effects and particularly significant longer-term effects like cerebral palsy, particularly if they're given early in the first week of life. And for that reason, we've been using them very judiciously in only the babies that really need them and often delaying their treatment until the second or third week. It would be fantastic if we could find a prophylactic anti-inflammatory therapy that acted directly on the lungs without the associated systemic effects of systemic corticosteroids. And that's where intratracheal budesonide comes in. So the idea here is that all of these babies really need to be, or nearly all of them need to be treated with Surfactant, which is for their preterm respiratory distress syndrome. And if we could deliver corticosteroid with that Surfactant, using the Surfactant as a vehicle to carry it into the lungs, then that could be a both effective and safe way to prevent or treat BPD.
Can you tell us about the primary outcome and how that was defined and some other key features of your study design?
Yeah, we had a primary outcome of survival free of bronchopulmonary dysplasia, which I think as the years go by becomes a more and more controversial outcome. Bronchopulmonary dysplasia has been traditionally diagnosed at 36 weeks post-menstrual age, so these babies are still in hospital when they're diagnosed with BPD and is clearly associated with worse longer-term respiratory and neurodevelopmental outcomes. However, I think there's a few things about this primary outcome which could be changed in the future. I think people are moving away from these sorts of dichotomized and particularly composite outcomes in the neonatal field. And one of the major challenges we have as researchers in this field is that survival is a competing outcome for many of the morbidities that we're interested in. So to put it plainly, a baby must survive to 36 weeks to be diagnosed with BPD. So having only a diagnosis of BPD without accounting for survival is tricky. So we went with that composite outcome, and that outcome is consistent with many major neonatal trials up until this point, including previous trials of this intervention, intratracheal budesonide.
What did you find?
Well, we did not find that intratracheal budesonide mixed with Surfactant significantly reduced the primary outcome. And that was disappointing, particularly on the back of previous smaller randomised trials that had shown a dramatic effect on this, with previous small trials showing up to a 1/3 reduction in death or BPD, or to put it another way, a 1/3 increase in survival free of BPD. So I think this tells us a few things. Firstly, there are always going to be slight differences between different trials. However, ours is a very large, pragmatic, and as you say, international collaboration that included extremely preterm babies who were both mechanically ventilated and not at the time of randomisation, and included different ethnicities and a very high-risk population of small babies, perhaps the highest risk population included in a trial this big. So we can state that in the babies enrolled in our trial and in the centres and countries that were part of the trial, we didn't see an effect. That's disappointing, of course, because that's what we wanted to see. However, it's also very important to do these large trials to show if something is effective before it's included into clinical practice.
I can imagine that there's still neonatologists who hope that intratracheal budesonide may work in some subgroups or may work under certain circumstances. Do you think that this trial completely closes the door on those possibilities?
No, not completely. There's always more to the story, isn't there? We did include a list of pre-specified subgroup analyses, including things like whether babies were exposed to chorioamnionitis or were small for gestational age. They're things in the past have been shown subgroups that have benefited more from steroids than others. However, we saw no effects in any of those subgroups that we looked at. We did, as a post hoc suggested subgroup analysis, include looking at babies who were in a lot of supplemental oxygen at the time of randomisation. That was more than 50% oxygen, consistent with the inclusion criteria of some of the smaller previous trials. And in fact, there was an interesting signal there suggesting that babies who were receiving a lot more oxygen at the time of randomisation may benefit more than those who weren't. But again, post hoc subgroup analysis and the interaction term between those subgroups was not significant. So something to think about, but not something that's proven by this trial. I think we can safely say that budesonide should not be rolled out across all of these babies because we're not seeing the effect that we hoped for. And of course, we wait for the results of other trials. There's one similarly sized trial going on in the US at the moment, and we will await the findings of that trial.
So for a neonatologist or other clinician, what is the bottom line?
The bottom line for me is that I would not introduce intratracheal budesonide mixed with surfactant into routine clinical use. I think we need to wait for the longer-term outcomes of the PLUS trial to see if there's any longer-term benefit or harm, and that can't be excluded just yet. Wait for the results of other trials and then work as a team across countries and collaboratively to see whether there in fact are any subgroups where it may be of benefit.
Well, I want to congratulate you, Brett, on this very impressive international collaboration. I'm continually amazed by what you neonatologists do with your ambitious trials. Thank you so much for a terrific overview of this very important study.
Thanks for having me, Tracy.
I'm Dr. Tracy Lieu, and I've been speaking with Dr. Brett Manley about intratracheal budesonide mixed with surfactant for extremely preterm infants. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.